Hello, can you hear me? LSA. Yes, I can hear.
Good afternoon, sisters.
Hello?
Hello. Mrs. X.C. Reed from Alimanya, this is Wednesday.
Yeah, hi.
All
Good
right.
afternoon. Yeah, I can hear you.
All right, good afternoon. So the session will start at 12. The guys are not I'm seeing okay. Can you hear us on the phone? Okay, okay.
Yes, I can hear.
All right, we're going to get started. This is the panel on maternal health, critical conversations on maternal health. My name is Oge Williams, and I'm an associate professor at the University of Buffalo. I also do work on maternal health. And today we have 4 panelists, originally 5, I believe, but we have 2 people in here in person, and then we have 2 presenters on Zoom. And they're going to have about 10 minutes to do their presentation, and then we'll go into the Q&A. I will introduce the panelists, and then they will do their presentation, and we'll move on to the next panelist. The first panelist is on Zoom, and that is Esther Ajayi. Esther is an assistant professor of women and gender studies at Texas Christian University. Prior to her scholarly journey in the US, she worked for over a decade in local and international organizations in Nigeria, focusing on human rights, gender, health, and development. Her passion as a scholar, activist, teacher lies at the intersection of gender, race, healthcare, and social justice. Dr. Ajayi's current research interests include indigenous birth and epistemologies, African feminisms, transnational feminisms, Black maternal health, global reproductive justice. She has published on sexuality, reproductive justice, decolonial pedagogy more broadly. Her current book manuscripts, Decolonizing Childbirth, Mothers, Midwives, and Modernity in Southwest Nigeria, is an ethnographic exploration of contemporary African indigenous birthing epistemologies and approaches. All right, over to you. You're muted. You're muted. We can't hear you.
Okay, I apologize. I was finding my own mute button. Warm greetings, everyone. Thank you again, Dr. Williams. It's really great to be here. It is an opportunity to be here on this panel. And my paper is really related to the broader theme of maternal health. But because this is a panel on just discussing about maternal health and then using cesarean section, the free cesarean section that was declared by the Nigerian president on November 7, 2024 as an entry point. And so that's what my paper is going to be about today. And I know that I shared my slide, but it disappeared for a while. Give me a moment. I'll circle back to it. Okay. I'll have to stop share. I'm sorry. And then share it again. Okay. Great. So I'm aware that I have 5 minutes, so I'm going to try and make it really snappy. My presentation is on C-section and maternal health complexities in Nigeria, and I'm going to be highlighting Berta's perspective today. And this is a paper that is walking through the potentials and possible dangers of just declaring free cesarean section in a country like Nigeria. So it's going to be a mixed bag, just walking through the complexities like the title dictates, to think about what are the potentials for this free cesarean section declaration, and then what are the possible dangers, and especially what are the birthers saying, the women themselves, the birthers, the pregnant people, the people who go through these experiences themselves, highlighting their voices. And I think that is really important for this. And really doing this, looking at the backdrop of the WHO framework on C-section, So they have a sheet on C-section, what it means, when it's required, and all that. So one of those bullet points for WHO is that preparing cesarean section or making it available, accessible, of good quality for birthers have the potential for saving maternal and infant lives. That is, it could really help us reduce maternal and infant mortality, right? And they published that in 2015, but it's still the framework that they have on cesarean section. So I'm looking at that and like, wow, so thinking about Nigeria as a country that has the highest maternal death rate, according to WHO 2023. When they measured in 2020 the trend in maternal mortality rate, Nigeria has the highest maternal death, but has the third highest maternal mortality ratio, because the ratio of maternal mortality is measured by the birth in percentage to like 1,000 births. So Nigeria, with the maternal mortality ratio, comes third after Chad and South Sudan. But thinking about the number of maternal deaths itself, given our population, we have the worst rate of maternal death as of 2020. So I think it's really a big problem. And the federal government declaring free cesarean operation section, just going in line with the fact that this could potentially reduce the number of maternal deaths for birthers who need medically indicated surgeries. And that brings me to the second question, that when it's really needed, when it's medically expedient and it is provided, it could also save the life of the birther and even the infant at birth. And thinking about the WHO, also thinking about what the rate of it should be, because I think it's also a body that is really thinking about, well, this is not about cutting everyone open to bring out their baby, but thinking about their framework, it has to be between 10 and 15%, given the population level, and that's the recommendation. Nigeria currently has the CS rate of 2.7, which means we're still very good. We're not one of those countries that have just high high cesarean operation for births. Yet, we also have to look at what this means for birthers, what this means for people who actually experience this, right? And that is my point today. So we could say, well, Nigeria has unmet needs, and so if they are made true, going by the WHO population of between 10 to 15, then it will mean that maybe there are some birthers, some pregnant people who are giving birth, who need a cesarean operation, but could be in a place where they could maybe not afford it, maybe it's not accessible, maybe it's just a lot of other reasons will not be able to access it. So just saying, well, we can pray for it and all of that, and then you'll be fine, by the federal government could have positive impact on maternal health in Nigeria. That brings me to think about the flip side of it. And so this is also according to WHO, because they also try to let us see the two sides of the coin, right? And as a scholar, I'm very critical of WHO, thinking about me always using the decolonial framework. But looking at their framework for cesarean operation, I think I like the fact that they covered both ends, and I'm using this framework to just provide a general background while thinking about cesarean operation in Nigeria vis-a-vis the global population. So one of the possible danger is that it can cause significant and sometimes permanent complications, disability, or death in settings, and I'm putting an emphasis in settings on this section of my bullet point, in settings lacking facilities and or capacity to conduct safe surgery. This is an important thing to note about Nigeria, because Nigeria as a country, we know we have inadequate number of facilities, we have low equipment, we also have low rate of medical personnel, when we think about the number of population and the number of people needing maternal health care. And also, when we look at the Abuja Declaration of 2001, which stipulates that funding for maternal health, right, for the African region needs to be about 15% of the budget. And since Abuja Declaration 2001, and even before then and up to now, Nigeria has only hovered around 5%. And I was expecting maybe, special fund that will be declared for this free cesarean operation. It might be available, but I haven't found it and have been searching. So if there's really no commensurate funding provided to cater for the needed equipment, facilities, and personnel that will provide the cesarean operations, then I think that more needs to be done than just the declaration itself. Because just saying, well, just do cesarean operation, it is free, and when there are no personnel or facilities or the equipment needed, it might portend possible danger. And I just need to really put in a personal story very quickly because my work on maternal health is also grounded in my own personal maternal experiences. In 2007, at the Lagos Island maternity, I happened to need an urgent cesarean section, and they didn't have what it would take to do that. And then they asked my people. My husband wasn't available, so everyone was available, my mom, and everyone's like, well, you need to go get this and that, right? We all know the traffic situation in Lagos. And I didn't come from a family where my people really understand some of these things. Would never expected would have this situation. And before they could, get back and know that it was already a bad situation, we had fetal distress. And that led to infant loss 3 days after the birth. And so these are some of the situations that needs to be addressed beyond just say that the surgery is free. And also thinking about the framework policy of free or partially free maternal health care in Nigeria has also been questioned by scholars, and I've also experienced that you would oftentimes have to pay out of pocket for most things that are technically or on paper needed to have been free for you to access. So that's one of the things that I'm questioning about this just free declaration of maternal of cesarean operation, if it's not backed up by everything that is needed to make sure that it is actually in place. I really also like these other points of WHO that there's really, and I think this really needs to be emphasized, there is no cause and effect, right, link between C-section, right, and maternal and prenatal and reducing maternal and prenatal morbidity or pediatric outcomes and psychology or social well-being, right? So this needs to be when it's needed. It needs to be in situations that are right. There needs to be a whole lot more that will go into, into the strategies, the policies before cesarean section can lead to the reduction in maternal mortality or infant mortality. So it is not something that directly leads to it. So without every other thing that needs to be in place, it might just really not work. And I think I also want to mention that we also have to be sure that this is not a policy that would become cesarean operation for people as the first line of point, maybe just to save time, maybe because it's just available, but we have to be sure that it is when it is medically expedient for the mom or for the baby. I'm also just, going to give a brief background of how I'm seeing this paper, and this is connected to my overall work. So this is just a snippet of my work on maternal health in Nigeria. And I'm always grounding my work in Black feminist thought, which validates individual embodied and felt experience as a source of knowledge. Right. And so it is also connected to reproductive justice scholar and activist framework, which centers birthers' standpoint about their own childbirth. So if we're going to talk about cesarean operation, if we're going to talk about maternal health or whatever under maternal health, we really have to center the voices of the people who are impacted, right? So we can't just have experts and policymakers make all the decision. And that's the reason I thought to give the perspective of birthers that I've interviewed over the years. And I think this also brings us to the fact that all policies and strategies about maternal health also need to include and validate aspects of African indigenous birthing knowledge that relates to pregnancy and childbirth. And this would include all the belief and worldviews and practices, and also includes Berta's worldview, because that should be part of that, because they're critical stakeholder in maternal health. So I'm just like going to introduce my research. I'm adopting qualitative methods and very, sensitive to using African indigenous research methodologies and really centering people's voices, amplifying their voices rather than just speaking for them. And then also making sure that I am also thinking about how all their voices are complex and not just either or. It is always a both and. Right. So this is a part of my project where I interviewed and spoke with and also observed birthers and traditional birth attendants in Southwest Nigeria, including Lagos, Ibadan, Abeokuta. And this was done in Yoruba language. So I was sure to be able to give them that platform to speak in their native language and be able to really express their view, which I'm amplifying. And these are in particular birthers who use the services of traditional birth attendants. So I wanted to make that clear, because this is only a section of birthers who use traditional birth attendants speaking about cesarean operation. Just in case I run out of time, this is the overall summary of their views around cesarean operation, because they have several views that I'm capturing. So this is just a snippet of it. They believe that their chances of having vaginal child delivery are higher with traditional midwives than skilled. I'm questioning that skilled, because that also pertains that traditional midwives or traditional birth attendants are not skilled. That's part of my overall work. And then they trust that traditional midwives will do their best to ensure vaginal delivery and will refer them to the hospitals as a last resort only if a cesarean section is inevitable. And I think this was more common in Lagos, where they have the referral process, which of course could be improved, but at least it's in place for traditional birth attendants to use. And then the birthers also say that skilled birth attendants in the hospital were always quick to do a C-section when they could have made effort to allow childbirth to take its normal course, and that they express resistance to unnecessary medicalization of or medication of child delivery. And these views were also corroborated by the traditional midwives themselves. And I'll say a lot more about this, because this also ties to other, of their perspective. And so I wouldn't want that to be taken as this is just what they said. This is one thing out of everything. And when I think about these quotes, I will explain further. So I want to use these quotes to express it. So the first quote was actually thinking about breech babies. Okay, and our breech babies and traditional midwives are able to help them maneuver and turn breech babies either by use of abs or just like hand maneuvering. And they thought that that wasn't the case in the hospitals when they go there. So they expressed that view. They also expressed the view of them not really understanding what is going on in the hospital, because most of the time the SBAs do not carry them along, right? And thinking about also that when they think that they're high risk or they've had one or two babies already, they tend to think that the hospital will say, well, you've had many babies, as you see the second quote, and then we need to cut you open. And that's what eventually happens. So just overall, putting everything together, betters think that the traditional midwives do better, but in the hospital, they think that the hospitals and the SBA, skilled birth attendants, needs to do more in explaining the situation about cesarean operation, making sure they do their best before that. And I think that's also an important way for us to think about Better's voice as very critical and central to maternal health and shouldn't be dismissed, because when we think about this also corroborates the fact that it needs to be medically expedient, and then it shouldn't just be available and free, but betters also needs to be carried along, and they need to be sure and ascertain that this is really needed and that it is a last resort, because this is their preference. And one could question why they prefer vaginal birth to cesarean section, but they're entitled to their view and the way that they understand that childbirth and the kind of childbirth that they really want to have, right? And I think all of this should be centered in how we think about policies and strategies, and in communicating these strategies and policies to birthers and pregnant people so they can understand it better. We don't just say, well, this is the policy now, and we all expect them to follow. They're critical stakeholders. And I also want to say that this can also inform the way we think about maternal health care more broadly, where pregnant and birthing people seem to be excluded and are not considered as critical stakeholders to hear their views. I will really see a need for other scholars to think about other birthers who go to the hospitals, other birthers who experience cesarean operation to give their views. I think we need a lot of birthing stories about how people experience and embody, whether it's C-section, whether it's vaginal childbirth, but how they embody and how they experience maternal health care, especially in the hospital, especially with the skilled birth attendants. And these stories can help us improve and fine-tune policies and strategies around maternal health care, including this very recent one of free cesarean operation. I mean, if we also all agree, or if we can all assume for the sake of argument that there are actually strategies in place to drive this declaration of cesarean operation. And I think that's where I'm going to stop, and we can take questions after that. Thank you so much, everyone.
Yes, we can continue this conversation during the Q&A. And then for those interested in continuing the conversation as well, we are going to have a roundtable at 5:30 p.m. So it will be more like an open forum interactive session as well. So we will do that at 5:30. All right, so for those in the room, I'm going to have my little thing. I'll give you a 1 minute sign and a time sign, because we have two other presenters on Zoom. Once I stand up, it's time, and I will cut you up shortly after that so that we have time for our Q&A as well. Our next presenter is on Zoom as well. She is Yetunde Alabede. Yetunde is a doctoral candidate at Michigan State University. Her research is situated at the intersection of language and schooling practice in Nigerian and Nigerian diasporic families, focusing on the holistic development of their children. As a mother, scholar, and community-engaged research activist, she examines mothers' birth experiences in relation to language use. And at leisure, she enjoys spending time with families transnationally. All right, it's a day.
Hi. Thank you so much. Please, can you see my screen? Can you see it now? Okay, thank you so much for the introduction. So I am Yetunde Alabede, and can you hear me clearly as well?
Yes.
I'm Yetunde Alabede, and as rightly introduced, thank you so much. But usually at times, just because of the kind of framework I do in my research, I try to also emphasize, like, yes, I am a mother myself and also a daughter. And why I try to bring that in is, yes, we want to talk about our research and everything, but trying to also humanize who we are. So on that note, I would like to say thank you for attending this session, and also saying I would want to embody more being a friend, being a daughter, or even being a mother as I situate my research. So today I'll be presenting on decolonizing maternal mortality for African continuities, cesarean section stigma in Nigeria from sociolinguistic lens. So I'll start with the introduction that in Nigeria, vaginal birth at times is widely promoted as the natural mode of delivery, which thereby perpetuates stigma against cesarean section. I do understand that things are changing now, and as such, I will give brief context of my work. Like when we say what is natural, what counts as natural? Why do we say it is natural? And also in relation to Ishiabe, which is cesarean section. I try to use that in Yoruba. And I think about this based on stories that we hear. And when I'm talking about my methodology, I will situate that well to ground it. Then also stigmatizing birthing experience. For instance, what stories are people saying when they have their child through cesarean section, and what does it mean for them? But before then is also thinking about, oh, what is happening? Hold on. Okay. Can you see my screen? It appears it's showing something here.
Now, we can see before.
Can you see it now?
No. Okay.
Okay, how about now? Okay, so here is a quote I would love to mention. Birthing is not only about making babies, it's about making mothers strong, competent, and capable mothers who trust themselves and believe in their inner strength, which to some extent, what does that mean when we think about the various contexts of how birthing experience is categorized or how it makes people feel? So again, I've talked about the first two contexts. Then the third one is what perspectives do we think, or how are people viewing trad medicine around birth experience, which Dr. Ajailo already talked about briefly in our presentation. Then because of where I'm coming in and because of the nature of my research, I would also try to connect it to what kind of language is used and how do people feel, how is this framed, and connecting it to what coloniality has done in thinking about the language used surrounding birthing experience, either C-section or vaginal birth. So in locating myself in this research is thinking about my lived experience. I just didn't come to this research, even though I'm a sociolinguist, is about what has been my experience in childbirth experience, what has been my mother's experience, what has been my grandmother's experience. I was to have a child through natural birth, just like Dr. Gailo shared. I had mine through C-section. But what does that mean? How do I feel about it? How do I talk about these things? And what triggers the kind of research that I do? Do I feel comfortable talking about it? Does my grandmother feel comfortable talking about it? Is my mother, did she have C-section as well? And how does she feel talking about it? What language do they use around it? And also connecting that to my scholarship, the kind of research is how is language used in a way to make people see themselves as less? Or how do they use language to amplify people's voice? But in this context, birthing experience, there have been instances of people saying, oh, if you have your child through C-section, I'm not sure I'm going to marry you, you have to leave my house. And this is somebody's lived experience that connects to the research I do. Then as an applied linguistics, again, how language is used in the society. Nigeria, that's what I've been going back and forth with, but to avoid the repetition, I'm just going to move on to the research question. So the first one is, how do Nigerian women talk about their birthing experience? And what does that mean? And the second one is, what is the implicit, that is the unspoken rules that govern women's language use about their birthing experience? And how do people backlash people when they say, oh, yeah, it is natural or it is vaginal? What does that mean? So these are the things that trigger me in looking at the kind of work that I do relating to birthing experience. So my framework, I try to look at two frameworks, and the first one is the decolonial framework here. So when I talk about decolonial, for me, I think more about it in my methodology. And what do I mean by that? Yes, we are collecting data. We talk about, is it case study? Is it ethnography? But how are we grounding it? Are we just extracting data from people? Are we using oral storytelling? What does that mean? So when we think about decolonizing methodology, I try to pick this framework, thinking about the intersection, the post-colonial framework, then thinking about here, the consideration of attitudes, values, and epistemological traditions of indigenous people. When I want to really talk to people and okay, this is what is happening, what do you want to share? Especially when we say people that are not schooled. I wouldn't want to use educated now because I understand we are all educated. How do I get in touch with them? Is there still that power distance when they want to share things with me? Saying, oh, and you tell us school. I'm sorry for those in the room that don't speak Yoruba, but like you that you go to school and everything. When I want to really get to have conversations with them, how do they see me? So my approach is like coming down to people's level. Do you want to share your experiences through stories? Do you want to share experiences through songs? And for me, decolonizing methodology also means that getting information or having conversations with people spontaneously, even though we still follow the ethical consideration. Then the other one, I look at linguistic ecology, which also connects to Brofeld Brenner's, a psychologist, having to do with the role of society from the microsystem. And here we have the child in the middle, like at the center of it in the microsystem. What is the home telling people about their birthing experience? What are they talking about? What languages do they use around it? Then connecting it to the mesosystem, thinking about the school. How are we being socialized to like talking about giving birth, and what does that mean as we grow up? Because when we think about it, a lot of things that we manifest now are things that have been inherent in us from childhood. And we think about the exosystem and the macrosystem. As I think about all this, is thinking about from home, how it dovetails to the larger society. And I was talking earlier about decolonizing methodology. So some of the things I'll be sharing today are based on stories, and I'll be presenting them as stories as well. And I get to use Araba Tutu's framework of African oral traditional storytelling. And what she says about that is that in the global north, or the Eurocentric way of talking about research, we are always thinking about, okay, we need to do this, put things in buckets. But who thinks about our African philosophy, African values, the way we do things that have been like, and Chilisa 2019 talks about as well, that we don't want our voices to be marginalized. So to do this, some of the things I'll be sharing were more of spontaneous storytelling from people. And that is why it will be presented from 3 generations of women, Yoruba people from the southwestern part of Nigeria. So the generation, the first generation had the child through Cesarean section. The story around it, why she had the Cesarean section, was not known because the story was shared with me by the second generation. However, one thing that is important about the first generation was how she was chased out of the husband's house just because she had the child through C-section. So here is the story. She was in the first husband's house and she had the child through C-section. Due to circumstances, not about the C-section, she had to leave the house. Then she married another husband who is wealthy. From the story shared by the second generation, it was shared that the wealthy second husband said, I have heard, you know how, and that's where African epistemology also comes in, the storytelling, how you hear buckets of stories here and there. So the husband then was like, I was told that your first child, you had it through C-section. I'm not sure I would want to accommodate that. And if you have that, that means you will need to leave my house. Now, this first generation woman had a child of this second generation through C-section, and she had to leave the spouse and the husband's house. And that, from the story shared, made her to still live in that shame and guilt of moving from one husband to the other. Again, linguistic ecology, how we have been framed about, oh, leaving one husband to the other, people not knowing the stories of those people, and we begin to shame them. One more minute. This woman lived with the shame. Then the second person, the second generation had the child, not through C-section. I can't hear you.
Sorry, please go ahead.
Okay, so the second woman never had the child through C-section, and she feels, oh, I'm grateful and everything. But to our child, which is the third generation, had the child through C-section. But unlike the story of the first generation, the third generation feels like, yes, it is C-section, and I love my scar of honor. And those were some of the things she said during having the conversation and through reflective moments. What is important here is thinking about how things keep evolving, how ideologies keep changing, which means the society itself is not static. So how are we embodying that from the shame and guilt, and how we are incorporating that into the society today? I think that is one important story that I would like to share in my research about the way it is viewed now. Lots of circumstances around it, but because this is a longitudinal way that I'm looking at things, I am still in the process of getting more data regarding that. Just from that story, I think 4 things that I just wanted to highlight is stigma that comes with C-section. Not even from men, but even from women ourselves. And what does that mean? Again, I am not looking at it from the lens of, medical perspective, but from the language use. Because there are ways that a lot of people talk down on people, and what does that mean? Yes, inadequate healthcare infrastructure. Do we think about this when we also look at, can we also go to the native doctors if we are in Nigeria or where we have the adequate resources? If the resources are not in place, what are the things to do? Then the ripple effect of colonialism. As I think about this, I think about how colonialism makes us forget our roots. I understand that there are times that maybe one of the reasons why you may want to have C-section is if the child is what they call big and cannot come out through the vagina. However, my understanding also is that there are always medications, herbs, that the traditional medicines, the birthers, let me use Dr. Ajayi's framing, the birthers, they can always give some of those herbs to make the baby smaller. But because of we want to be more white than the white people, then we may not really want to adhere to some of those things. So as we think about all this, is like, we don't want to forget our indigenous knowledge and think about how important they are as well. Then limited education contributes to high mortality rates. And to just end it, because of the next presenter, is that to some extent, regardless of the language used, a C-section might not be the birth you envisioned, but it doesn't diminish the value of your experience. So we want to really embrace that. And just me thinking about the implication, and maybe when we have opportunity for questions, I'll be able to talk more because this feels rushed, and I apologize. Thank you.
Thank you for a wonderful presentation. We definitely want to hear more of those stories in the Q&A, and I'm sure somebody will bring it up. So I'll talk some more in the Q&A. Our next presenter is Karimat Ajoke Lawal. Karimat received her BA in History and International Relations from Obafemi Awolowo University and an MA in History and Strategic Studies from University of Lagos. Her research focuses on gender, reproductive health, and social policy in Nigeria. Karimat's recent research examines the socioeconomic history of abortion in Ikorodu, Lagos. This research explores how legal, cultural, and economic factors shape reproductive health outcomes in underserved communities. Karimat is passionate about using historical research to inform inclusive public health interventions and gender-responsive policy making, and she is currently seeking PhD opportunities to advance her work. Thank you.
Thank you very much. I'm going to okay, thank you very much. So my name is Karimat, and I'm glad to be here as a first-time presenter, aside when I'm in class. I'm a master's student or an undergraduate student. So my presentation today, permit me, I'll not be sharing because I have a lot of rope work as a beginner. So the title of my presentation is Socioeconomic History of Abortion in Ikorodu and its implication for maternal health and reproductive justice in Nigeria. Okay, so what this basically examines is how historical, socioeconomic, and cultural factors, how to shape abortion practices in Ikorodu, Lagos, and the implication of maternal health in Nigeria. So the methodology used was qualitative, with 18 in-depth interviews with women and children, with women and men, and the 5 informal interviews for health providers and traditional healers, healthcare providers, being doctors and nurses, and of course the LMO nurse. and also focus group discussions with community members of the community. And the key findings of this work is that economic constraints drive 80% of abortion decisions. And 60% of the respondents also revealed that they also utilize traditional methods and combine it with pharmaceutical intervention, which are drugs like among others. Okay, so this study also documents community-specific practices that you need to produce repertoire content. All right, and then I'll move quickly to the problem statements and also the objective. Okay, so according to the Gujarat Institute fact sheet report that was published in October 2016, the Nigerian restrictive abortion law makes the country maintain one of the world's highest abortion rates, just as Dr. Ajayi has said and Mrs. Labede has said. Okay, so and I said that the rate is 33 per 1,000. According to the 2015 fact sheet, 23 per 1,000 women between the age of 15 and 49, they experience abortion. And it's also dramatically increased from 210,000 procedures as of 1996 to 1,050,000 in 2012. That is a lot. And this is also true to Ikorodu, which is Ikorodu has proximity to advanced healthcare and there are lots of private hospitals in Ikorodu too. But this is not even translated to, or it's not even reducing the maternal mortality from safe abortion practices. And this is also persistence of the persistence of the traditional methods alongside the pharmaceutical combination reflects a gap in understanding how the historical, socioeconomic, and cultural factors how they intersect to shape the reproductive health outcomes in Nigerian diverse communities. Okay, so the aim of the study is just to analyze the socioeconomic determinant that is driving abortion decision making in Ikorodu, to examine how traditional knowledge system interact with modern pharmaceutical intervention, and of course provide evidence-based recommendation for community-specific maternal health intervention. Okay, so moving on, women in Ikorodu continue to suffer lasting health consequences, and in most cases die from preventable abortion complications. And this raises question of how we have maternal health intervention in Nigeria. So understanding these factors, we offer crucial insights for improving maternal efforts across not only in Ikorodu, but across similar communities in Nigeria. But before we can also understand the contemporary practices of abortion, it is also imperative to examine the existing literature, of course, what the scholar have said and stuff, such as the major works have been filed also in this and Gujarat Institute, where they said there has been continuous increase in abortion despite highly restrictive legal framework. So it's not even the legal framework of abortion is not even diminishing the rates at which people experience abortion, especially the safe abortion. Also, there has been regional disparities that suggested economic factors are connected to reproductive health outcomes. The work of Bankole Adewale, which is the incidence of abortion in Nigeria, also reveals that abortion rates ranges from 27 per 1,000 women in Southwest and 44 per 1,000 women in South-Southern. Also, this shows that there are levels. This shows the very levels typically shows that there was abortion that perform or women perform depends on the contraceptive access, the fertility preferences, and economic conditions. And all this contributes to high abortion rates in different parties. Also, the Nigerian Demographic Health Survey that was conducted by the National Population Commission and in 2013, and also ICF International. ICF means International Classification of Functional Disability Events. Also reviewed low contraceptive usage, and it's revealed that only 11% of reproductive age women use modern contraceptives. This was in 2013, and this estimates that 40 million women lack access to modern family planning services, and this contributes to unintended pregnancies. From these unintended pregnancies, 56% of the unintended pregnancies also ends up in abortion. And one pattern that is seen here is that abortion is more or less like a de facto family planning method. I mean, if a woman cannot access the family planning, yes, so when they get pregnant, the next thing is abortion. Yeah. So okay, so also I'll move forward to Okay, what I just said is that the existing literature has largely focused on epidemiological data and policy analysis, but there has been limited ethnographical engagement. This is to examine how women express emotional decisions and within the cultural context. This is exactly why my study is limited to Ikorodu as a community. Okay, so the gap is just that that was why the study addresses gaps by providing a geographical analysis of Ikorodu unique, because Ikorodu is also unique. It's a neo-urban environment. Ikorodu is not only, it's not urban, but it's not also rural, like it's mixed, exactly. So to understand this contemporary factors, we first examine the historical foundations that shape current abortion practices. Okay, so that's where we'll now start from before the advent of colonialism, of course, before British colonial intervention, where the communities in Ikorodu already expressed sophisticated reproductive health system, which is they already integrated it into the traditional medicine practices, where the elderly women, they call them the Yoruba, Iya Iboye, Edebe Omo, and they serve as reproductive health specialists. They possess extensive knowledge on indigenous abortive patients, plants, and other methods that are passed through generation. So based on the findings and the field findings, okay, they use plants like citrus medicinal, which is the where they use ewuro, and they use I'm sorry, these are Yoruba terminologies because of course I have to interact with them in Yoruba. Of course, they are the English words I heard, so which is the Artemisia vulgaris, the Acacia silveriana, which is they call the tree arrowroot from tree. Okay, so they combine all these things together and made an antidote out of it. So this means that pre-colonial society had they already had ways to which they approach abortion practices, which then, according to the areas that I spoke with, it's quite safe because these things that they are done based on the gestational timing of the pregnancy and also after proper ritual observance. So, but however, with the British colonial administration, which introduced the criminal code in southern Nigeria, so we are focusing on the criminal code in southern Nigeria because it is related to Ikorodu that permits abortion to only save the pregnant woman's life, and violation is punishable by up to 14 years imprisonment. So these restrictions are rooted in British colonial statute, created like a destruction of the traditional reproductive system. And this colonial criminal code also fails to recognize indigenous practices or even accommodate the local cultural context to which the reason why people perform abortion, they just tell them that they are going to perform abortion, it's only to save the life of the pregnant woman. Excluding the factors like incest, rape, even the health of the child they are carrying. Exactly. So this also explains why contemporary abortion practices in Ikorodu still operate largely in legal and cultural limbo. So it is not really traditional, neither is it modern. So this, which brings us to the methods and practices of abortion in Ikorodu. The most documented method includes missing postage. Oh wow. So they use potash, they use citrus fruit like local gin. This is corn, the potash is corn, ogogoro, which is the local gin, and also some way. So there's also a very distinct method, which is the that kind method, which is quite distinct. They tie a wrapper very tightly, and the woman will give scarf like turning yam, like fetching water. So, and this local unit was set like it brings menstruation in 2 to 3 days by the time they use these things too. So now based on the feedback that we had, I had to and some of the respondents explained, but I'm not able to get their story because of the time constraint. So this also the socioeconomic determinants of abortion, of course, economic factors, which is the leading cause, and also the young women view education as still teaching at the pathways to economic mobility. They don't want to get pregnant because they feel that it threatens their long-term economic security. So they tend to pick economic stability or education over pregnancy, which is why they engage in abortion. Also, I will move quickly to another reason that another determinant of abortion in Ikorodu is the kinship structure, where sometimes the family supports the abortion practice, while other times they do not support. So this means that for people that their families support, they're able to make earlier choices like visiting the traditional healer or even private hospitals sometimes if they can afford this. But for people that their family do not support their abortion, they tend to do it in secret and term it as a miscarriage. Yeah, so that's another determinant. So I'll move to these studies, basically my studies have been able to reveal that the practices of abortion in the pool and emergence of historical legacies in socioeconomic constraints and the cultural adaptation. So most critically, what I would like to say is that in order to turn this into the today's conference and the panel title is that unsafe abortion practices that is documented in this study, they sometimes lead to complications that require emergency surgery. That's like a post-abortion complication, regardless of if it's safe or unsafe. So what I'm trying to say is that the surgical intervention that this cesarean policy that federal government is trying to aid, sometimes are even used. So there is no way we can want to address this cesarean section without addressing unsafe abortion. So even trying to maybe we have a policy reform to liberalize abortion. All right, so okay, I'll be talking about my representation when we have the discussion. Thank you, and I look for feedback.
All right, thank you very much. Our next presenter is Kingsley Ogunle. Kingsley is a postdoctoral researcher whose scholarly work sits at the intersection of politics and public health, with a PhD in political science from Obafemi Awolowo University. He has led and contributed to a wide range of policy relevant and interdisciplinary research initiatives. He is a recipient of the prestigious David Watkins Equity Catalyst Award 2024 to support his research on obstetric fistula interventions in Nigeria, a project aimed at informing more inclusive health policies. Dr. Ogunle is a fellow of the Ife Institute of Advanced Studies, amongst other organizations. His work has been supported by the Swiss Plexus, Johns Hopkins, University of Nigeria, Health Systems Global, and the LSE.
So once again, good afternoon, everybody. I'm a political scientist by training, but I have an obsessed interest in the WHO and the World Bank's combined report published in 2025 looking at maternal mortality as of 2023 shows that 95% of all maternal deaths are occurred in low and middle income countries. And looking at year 2020 down, year 2000, 2003, there has been 40% reduction in maternal mortality globally. However, in spite of this reduction, 700 women died daily from pregnancy and delivery complication, which translates to one woman dies every 2 minutes. Still shows that we still have a long way to go. And when we bring this down to the country level, we realize that Nigeria alone contributes 28.7% to global maternal death. That means that Nigeria alone, as just one country, contributes over a quarter to maternal mortality. This shows the state of Nigeria's maternal mortality that is of great global concern and of great significance. And then, if this is the case, this work is then interested in looking at how can we deeply look at issues of maternal mortality beyond the known epidemiological processes that we've seen in health sciences, research, and all of that, and dive deeper into some of the causes, and that is why we're using a political economy framework to look at this study. And in the process of that, one of the things we realized was that in addressing most global health issues, the tool called universal health coverage, which is the target of the SDG, has turned out to be a very vital tool in addressing critical health issues such as maternal mortality. And maternal mortality has come in as a central tracer of measuring universal health coverage in countries. But then, to achieve universal health coverage in countries goes beyond medical or technical terms, it is more of a political decision, because to achieve that, we'll be talking about resource allocation, we're talking about interest of political actors, we're talking about having the right infrastructure to ensure that we reduce the rate of maternal mortality. So basically, UHC is a political choice, and that shows one of the importance of analyzing UHC from a political economy dimension. So for this research, we aim at achieving this objective. One is to critically appraise the frameworks, policies, and programs targeted at achieving universal coverage for maternal health in Nigeria. Two is to explore the political and economic variables affecting UHC for maternal health in Nigeria. And three is to describe the current state of UHC for maternal health care in selected subnational locations. Now, in simple terms, UHC means that there should be that people, all individuals of every country, should have access to quality healthcare without suffering financial hardship. That is the basic tenet of UHC. For our methodology, we adopted the multi-stage sequential explanatory mixed method design. That is to say that we combine both quantitative and qualitative research method to achieve the aims of this study. And that process was in phases. The first phase was to run a statistical analysis of maternal mortality trends between 2000 2003, which is the latest report by WHO, UNICEF, and the World Bank. The second phase is to conduct an historical analysis of maternal health policies and programs in Nigeria. And having done this, secondary data analysis, then all of that informs what we go out there on field to achieve with our primary data collection process. So we had a survey with 352 women of reproductive age. We also conducted 20 key informants cutting across stakeholders and the federal, states, level of policymakers, program managers, and PHC providers. Ethical approval was obtained from the IPH of the Babangida University, and as well the Osun State Primary Health Care Development Board, because Osun State was the subnational location that was selected to assess the current state of universal health coverage for maternal health in Nigeria. So this are just pictures. So the fourth thing was to do a statistical analysis of maternal mortality trends between Nigeria and its peers. What we meant by peers is that as of year 2000, Nigeria, alongside the countries listed here, were categorized as having extreme high maternal mortality rates. And you can see that, let me see, okay, this is it. So fast forward to 2023, most of these countries have reduced their maternal mortality rates. For instance, a country like Afghanistan reduced its maternal mortality rate as high as 4%, some at 40%, some at 35% from 2000 to 2003. Unfortunately, Nigeria only reduced its own maternal mortality rate by just 14%. That is the lowest globally in terms of reduction in maternal mortality rate. And then we also looked at the rate at which this reduction occurred yearly. So we have what we call the annual average annual rate of reduction in maternal mortality ratio. You can see a country like South Sudan had about 12% yearly reduction. Fortunately, this is a country at the lowest of having just 2% of annual reduction in maternal mortality. And then this is just the general changes. You can see a country like Sierra Leone having a very large change between 2000 and 2003, as high as 70+%, but yes, Nigeria of just 14%. So in terms of having an analysis of the policy and programs targeted at improving maternal mortality, we realized that there has been an avalanche of policies and programs in the country. And here is a list of policies and programs since the 1960s, and then the list goes on to these and to these to the latest, which the latest is the Maternal Mortality Reduction Innovation Initiative, called the MAMI initiative, in which free Cesarean operation, which is like the core of our conversation today, was introduced to have free Cesarean operation for pregnant women. So in terms of the quantitative, so all of this informed what we then went out to the field to assess, to now look at the state of things, the state of maternal health at the subnational location, which is in this case was Osun State. We realized that antenatal care utilization was quite high. The place of delivery seems to be 65% in health facility, while 35% of beds were at non-medical settings such as home, religious centers, mission houses, and through traditional birth attendants. And then postnatal care was high in PHCs. So if postnatal care was high and then delivery was slow, it shows that women seems to, because after delivery at some point, at some interval, they need to take the kid back to the hospital for immunization. We realized that at that point, PHC visit was very high, but the delivery at the PHC is quite low. It means that there is a level of trust that women have with health facilities when it comes to delivery, but when it comes to getting immunization for their kids, it was very, very high. And then infrastructure deficiencies. We realized that only 44.4% operated 24 hours. And that has implication. It means that there's an emergency overnight. There is always such facilities to respond to such a patient. Then human resource, the 9 PHCs that we surveyed, not one had a doctor. Not one had a medical doctor. Most of the PHCs are led by what we call community health care workers, CHU and CHU. And then the referral system was very, very poor across the PHCs. And this has implication for even the program that the federal government is trying to come up with. Because if a woman goes to the PHC and then she develops complications, there are no referral system in place to really take that woman from the PHC to the nearest tertiary hospital where such a serious operation can be carried out. And this, I don't some of the things we saw on the field. This is a delivery couch, and this is what we found across all the PHCs that we assessed. Meanwhile, this is the ideal delivery bed that hospitals should have, but what most of the PHCs had was not delivery couches, so we can't call them beds. And then in terms of transportation for referral, some of the PHCs we visited actually had abandoned, transportation system. It shows that in the past they had provision to really take patients for referral to higher level of care. But as we speak now, the old PHC that we surveyed, none of them currently had a functional transportation system for referrals. And then the third aspect of every UHC analysis is to measure the financial risk protection. And then in this case, there were challenges that we saw. Only 9.2% of women surveyed were on an health insurance. And then let me quickly run through. So in terms of the qualitative analysis, these were the issues that we found out. Perhaps in the course of further conversation, we can look at these issues. So the recommendation as listed, which would have impact for the whole initiative that the federal government has just introduced. One of such is to increase budget and resources allocated to health, which would have implications for maternal health, strengthen partnership, provide functional ambulances, especially for referrals for women with complications, and a whole lot of other recommendations. So conclusively, we say that the study concludes that while progress has been made, though minimal, the persistent challenges identified in this study highlight the need for continued and focused effort to bridge the gap between policies and practice. The policies are always there, but policy implementation has been a constant problem. So achieving UAC for maternal healthcare in Nigeria will require sustained commitment, targeted interventions, and a collaborative approach involving all levels of government, healthcare providers, and the community. So to me, I'll say that in all of our efforts, we must ensure that no woman should die as a result of giving birth. Thank you.
Our final presenter is on Zoom as well. That's Ambassador Dr. Elsie Halimari. Elsie is a certified traditional medicine practitioner with the Federal Ministry of Health and a trained holistic wellness practitioner from Hills College, Texas. She's also the CEO of Halimari Holistic Wellness Center, where she leads integrative health solutions for women across fertility, pregnancy, postpartum healing, and reproductive wellness. Dr. Reed serves as the Director of Research for the Islamic Association of Alternative Medicine Practitioners of Nigeria, Public Relations Officer for the Abuja chapter of the Association of Integrative Medicine Practitioners of Nigeria, and Distinguished Patron of the West African Postgraduate College of Natural and Integrative Medicine. She has trained in multiple herbal medicine programs in both the United States and the United Kingdom.
Hello. Can you see my screen?
Yes, we can see it.
Hello? Hello?
Yes, we can hear
Hello?
See and we can hear you. We can see and
Hello?
we can hear you. Hello, we can see and hear you, ma.
Hear me?
Yes, yes, ma.
Oh, okay. And you can see, okay. Thank you. Good afternoon, everyone. I'm not going to be talking as a scholar today. I'm going to be talking as a traditional medicine practitioner and somebody that is close to the TBAs and also close to the clients. My paper is about honoring tradition, that's bridging the gap between modern medicine and cultural practice in maternal health. 20 to 21% of births are being done by the TBAs, and about another 20 are done outside the hospital setting. So if we put all that together, you will see that only 60% are being done in the hospital by the midwives. And interestingly, I've been listening to the other presenters, and I see that there's always a link to the TBAs. And so I feel that it's necessary because no matter what we do, no matter what law comes into place, the TBAs are not going to go away because they have developed trust with their community. So I'm going to start by a story. 2 years ago, my goddaughter, who works with a prominent family in Abuja, one day the driver came to work and he was very, very sad. And when they asked what happened, his wife passed away during childbirth in the hospital. The man wanted nothing to do with that. Can you hear me?
Yeah.
Hello?
Yeah.
Okay.
But we can
So,
hear.
pardon?
We can hear you,
Hello?
We can hear you, ma. Maybe they need to.
Oh, okay.
So we can't hear with us.
Oh, okay. So this driver wanted nothing to do with the child. He refused to take the child home due to grief, confusion, and I think he blamed the child. And so my goddaughter she already has 2 kids. So she took in the child and she's been raising the child as her own. The child is now 2 years old. The mother is gone, but the child is still alive. And this made me question her death. And it's not a unique story. It's one of the many cases that happen in Nigeria. Okay. So it made me ask myself many questions. Why did she die? Was it poverty? Was it delay in care? Or was it fear of being judged? Like Dr. Ajayi said, when she talked about cesarean operation, we see that a lot of women are scared, actually are stigmatized. I've heard a lot of women say, you born your own natural. Me, I not born my own natural. And there's this stigma surrounding C-section. So from my studies, I've found out that a lot of women are actually scared to go to the hospital because they don't want to have C-section and because they trust the TBAs more. And that's because the TBA has been in that community for years and she's given birth to so many children. And so they trust her more than the doctor. So this made me question a lot of things and ask myself that if both parties could work together, that is the maternal, the midwives and the TBAs, if they work together, whether they will be able to lower the maternal mortality. So this slide is about me, but I'm going to skip it because I will just talk about, before I entered the wellness world, I was an IT engineer and a data system consultant for over 2 decades. One of the defining roles I had was working as a data warehouse manager with the US Department of Health. I designed and produced maternal and infant mortality reports under the Clinton administration. The experience taught me how data could drive health policy, but it also showed me how data often ignores culture, trust, and community wisdom. Excuse me, I'm trying to rush. Okay. So Nigeria accounts for over 20% of global maternal deaths, and that's 1 in 5 deaths worldwide. And the maternal mortality rate in Nigeria, it's about 814 per 100,000 births, which is one of the highest in the world. And the causes, like medical will say it's due to hemorrhage, septics, and all that. But it's also about poverty, poor transportation, verbal abuse in the hospital, judgment, cultural shame, and medical mistrust. Many women avoid hospital altogether. Some arrive very late, and we keep losing them. So like I mentioned earlier, across Nigeria, so many people use cultural methods. And one woman I talked to actually told me that that's in Warri. She said to prevent tear, she had a woman massage her stomach with herbs, and that shrunk the baby. And she said the only time she had tear, this was interesting. She said, "Oh, ma, I had 4 children, and all of them, 3 of them, no tear. The only time I had tear was when I refused to go to the woman, and I went to the doctor instead." Across Nigeria, like in the south, they also use herbs for massages and also to prevent complication. One place I was told that after women give birth, that it depends on the sex of the child, they made the woman drink only pap. So I think if it was a girl, she drank only pap for 4 days or 3 days. And if it was a boy, then it meant that she drank only pap for 7 days. Think of what that will do to a woman that lost blood during childbirth. And hello? Yeah. And I won't say that, yeah, I won't say this practice are foolish. They're not foolish. They're full of wisdom. But because they are unregulated, this causes a lot of damage and sometimes very, very dangerous. And so, and our hospital often regards tradition as superstition, and that rejection leads to fear and also the cost of life. So my research is ongoing, and so I will be doing excuse me, sorry. So my research is ongoing, and I will be doing it across the 6 geographical zones, and I will be interviewing TBAs and health workers, and also reviewing policies, studying women, trust around labor and delivery, and also reviewing the national maternal health policies and training curriculum. And my aim is not to replace hospital, but just to make a space where both tradition and science could work together. So what I'm asking is not, I'm not the first to ask this question. And in Ethiopia, maternal death was dropped to 38% when community health workers were trained to serve local women. And also in Indonesia, traditional birth attendants called dakon were paired with midwives called bidan, and the maternal death rate in Indonesia fell dramatically. Why this will work is because it's not a war between tradition and conventional medicine. It's actually a marriage between both. Okay.
You have 1 more minute.
Oh, sorry. So my vision is very, very simple. It's a system where Nigeria honors the woman's culture without compromising their safety, where herbs are validated, where herbs are, sorry. Okay, studying the women trust behavior around tools and delivery. Like I said before, our aim is not to replace the hospital, but actually for both to coexist. The girl is that's the girl my goddaughter is raising is alive today, but her mother didn't have to die. So I'm hoping that her story will not be repeated. Thank you.
Thank you very much. All right, thank you very much. Obviously, this is a very timely presentation and one that continues to be relevant. For context, in November 2024, Nigeria, the federal government announced a free cesarean section project, and a quote from the Minister for Health says, "No woman should lose her life simply because she cannot afford a C-section." Laudable goal, right? But from Dr. Ajayi Lowa's presentation, we can understand that it's not as simple as, oh, 3 CS. And that solves the problem. How about the infrastructure for the CS? How about the facilities and access to those facilities to get to the CS, right? Because when you need a CS, it's a critical emergency. And we've come to this conversation about maternal health from different angles. Dr. Ogunne has painted a very clear picture of what those numbers look like. And he did point out that the numbers have stalled for Nigeria. Like, seriously, the countries we are competing with in terms of maternal death rates is Afghanistan and South Sudan. What does South Sudan and Afghanistan and Nigeria have in common? South Sudan and Afghanistan have something in common. These are war zones and these are very, very unstable places. Nigeria is right there with them. Numbers have reduced across the world, across Africa. Nigeria has stayed stalled for over 2 decades. So I hope that we have time to get into what the problem is. And my sister right here did great for the first time. That was awesome. She has come at this issue from the abortion angle, right? It's a sensitive topic that Nigeria does not like to confront, right? But the fact remains that 25% of all maternal deaths is sometimes 27. So let's just say between 20 and 30% of all maternal deaths are from abortion-related complications. So like she said, we cannot ignore conversations about maternal death without engaging abortion and what we have to do with that, with that crisis that is abortion. So on that note, I'm going to open it up to the floor. We have about 10 minutes, not a lot of time for Q&A. And 8 minutes. Let's have a question. Okay, and we'll open it up to the audience, and then we'll try to get the questions from online. Questions? Yes. Okay. Name, affiliation, question.
Just an issue for the doctors in the first case. My question goes to it's the other day. On your forensic framework, you mentioned post-colonial. I just want to provide a suggestion on the way you wrote it down. There was a item in between post and colonial. If you are suggesting a theory, that means checking what happens after colonialism. The item shouldn't be there at all because with the item there, it means the period after colonialism and not about the exact theory that you meant to put there. So in this context, the word post-colonialism is a block compound written together and should not be related or space. So maybe that was just a suggestion. Thank you.
Did you hear the comments? Are those on Zoom? Could you hear us? The comment from the
No.
Okay. So that's a comment. Do we have other questions from the audience? Yes.
Action. You asked me to read for long language. So my question is out of curiosity, actually. You were able to interview women, is that so? Yes. Okay, so how were you able to make them, because I know that abortion is sensitive, like you mentioned. So how were you able to make them say things to you? That's just
Honestly, it was difficult. Absolutely. It was a big because of this. As a matter of fact, as soon as you get to people, by the time you tell them, you have conversed with them, telling that you're not just leave this for study. Then also make sure you guarantee and everything. They are not mentioning their name in any point. And it's still extremely difficult, especially when you now bring out things to record. And you need the evidence to aside, you need to go and listen to it again because that's just consulting. Overall, you might have made that is why the numbers are reduced, honestly. Even they are not only women or men, even men practitioners, people that are like educated per se,
they are not even willing to talk about it. But you just the idea was to talk about this. So if the perspective is coming from this is what was by the time you ask them, although most of them don't even know the input frameworks of adoption, but by the time you explain to them this is this is what we are trying to do, and come policy, and then they be lots of. Like you will have like a recent paper or something like that to address these things. Just make them comfortable. Then sometimes you have to follow their leads. I know that you have structured questions to ask, but let them by the time they say one thing, if it moves to another, let them move to the other. Just have to be the one to there are things you need to prepare.
Absolutely. Based on my experience, you do not lead with that question. You shut down. You begin with the general, and then they get comfortable, and then they get to that subject. But the foundation of that is right, absolutely. Any other questions? Yes.
Yes, my name is Angela, like it said, and the comment for is today around the trip. I like the perspective and the direction. And I just want to suggest moving into the role of culturally sensitive health education, the role they play in using indigenous languages to sensitize and then to decolonize maternal health narratives. So that would be something you might be interested in looking at. Thank you.
Ms. Jessina, did you get that? Can we close up, please?
No, I'm sorry. Maybe you can help me recap it, like probably sitting and those sitting on. If we can.
Okay, can you hear me now?
I can hear you now. So please, do you mind repeating what you said, Ma?
Okay, thank you. I was saying that you may want to also consider looking into the role of culturally sensitive health education and how the role they play in sensitizing and then decolonizing maternal health narratives. So I feel that would benefit your work so much. Thank you.
Thank you.
All right. Okay, yes.
All right. Actually, I want to appreciate God
So can you be audible?
for the wonderful presentation. My Oga presented on his presentation has to do with the policy issue. And I realized that in Nigeria we have so many good policies. But when it comes to implementation, I always have issues. It's not only on maternal issue, but there are good policies everywhere. My question is just maybe for everybody, not really for him. What can we do as academics so that all this discussion will not just end in this room? What can we do beyond the publication? What can we do practically that will make informed decision, or that will make the government make informed decision, so that all these recommendations and good policies will put into?
Okay, so that I can answer it. And that's why I said don't take the one answer.
Okay.
I have a question. What role does traditional healers play in session on maternal health complexity?
Okay, so for the presenters, we'll take these two questions together. What can we do as academics to keep the conversation going and to force change, policy changes? And then what rules do traditional healers play? Who wants to? Anybody can jump in. Okay,
I can jump on the first question. Yeah, thank you for the question. We appreciate that. That's actually a really good question, thinking about all the presentations today. So how do we translate all of this into practice? What more can we do beyond the scope of, presenting to, scholarly communities? And I think one of the things that a few of us here have been doing is, publishing, right? And then hoping that, this goes out and people can find it. In my own work also, I'm using I'm using my voice to really amplify the voices of the birthers and the traditional birth attendants beyond just, publication and presentation, but also speaking with people that I'm connected with at the local government. Just like thinking about the people in charge of the Ministry of Health and local government, thinking about what more can be done, relaying the things that I heard from the traditional midwives to them. And for instance, is one of the things is about like how to make the referral process work better. So for instance, in Lagos State, and I spoke with traditional birth attendants in Ebutemeta, Yaba area. One of the things that they all said is, well, so this policy is in place that you can refer. We've been trained by Lagos State, we've been given these certificates, and then we have these forms, right, to refer to hospitals like, Island Maternity and all of that. But when the pregnant people or birthers also go to those places, they get turned back to say, well, we don't know what you've been drinking, we don't know where you've been, we can't take you in. So there's also that lacuna. So for them to be able to look into that, and so in their training, more training for SBAs, cultural training, and when they speak with them to say, hey, we need to take people when they're coming from the traditional birth attendants because it's, it's part of our policy, just for them to ensure that that gap is bridged, in their own capacity. So now, and I think this is also a great way to step into it. And I would really encourage everyone who has a voice to actually speak up, because this is really, like we've seen in all of this presentation, it's really a big problem. And not only has Nigeria stalled in reducing maternal mortality, it's actually worsen. When we think about the MDG, yes, and I'm thinking about the SDG, which is also one of my questions, that there hasn't been any improvement from the MDG SDS. It has worsened. When I started this work on maternal health around 2016, 17, 18, and working with the MDGs, we had the fourth maternal mortality ratio, right, in Nigeria. Now we are the third maternal mortality ratio, and now we actually have the highest maternal death. So there's actually been a retrogression, which means that we're likely losing more people to maternal death. And it is not enough to just give policies or have paperwork like we usually do. I love how you frame that question. That's one major problem. We have policies, but it just never translates into implementation. We have to be sure that our voices are heard. Everyone who has a voice needs to let everyone know that maternal death is a big, big problem in Nigeria. So we need to start creating that awareness, right? So I think that's one way that I see this. And if you have the time, please join us later this evening, 5:30, for the critical conversation on maternal health, because we're bringing in people who are working on the ground, people working with NGOs. We're bringing in doctors, midwives, who will actually speak about their experience, and then we can convey to them what things we need them to do more, right? And also hear from them. So I think this scholarly activist bridge also would be one way to raise awareness about this issue and possibly get some of these policies to be translated into implementation. Thank you.
All right, we are out of time, so we will not take any more answers to that question. But please, like she said, join us at 5:30. There will not be presentations. It's going to be a conversation, Q&A, and we're going to have people like doctors, actuaries, and then us academics having that conversation. Thank you very much for attending.